Hello everyone, and welcome to ERS Satellites 2023. I'm Richard Costello. I'm a clinician from Dublin, and I'm the Chair of Education here at ERS. And joining me today to co-host is Professor Nicolas Roche. Nicolas is a chest physician. He works in Paris. He's a professor of medicine, and he's the Chair of Science. Nicolas, it's nice to see you, and thanks for coming along.
Yeah, thanks, Richard. Actually, it's a great pleasure. This is our second session of the day, and which will be on COPD. And really, we are lucky to be here. We have this organized by the ERS with 4 national, or some of them are international actually, societies. And we have 4 national society chairs, which I'm going to introduce to you. Starting with Dr. Bernardino Navarrete, who is Associate Professor in Respiratory Medicine, working in the University of Granada in Spain. So Bernardino, nice to see you again here with us.
Hi, Nicola and Richard. Hi to see you again. And thanks for everyone to be involved in this project of the ERS satellites. I have to say that I'm delighted to be here, and thankfully for the ERS for inviting me to chair or to chair this session. I'm professor of medicine in the University of Granada, and also work as a chest physician in Hospital Virgen de las Nieves. In Granada, I'm very focused in COPD, so I'm just looking forward for these new presentations to bring us more evidence on this disease.
Thanks, Bernardino. And now we have for the French-speaking, French language respiratory society, which we call SPLF, Société de Pneumologie de Langue Française. We have Professor Cindy Barning, who is working in the University Hospital in Besançon, in France. And Cindy also has a role in the National French Language Society as lead of the what we call the G2A, which is the group on asthma and allergy. Cindy, welcome in Geneva, virtually.
Hello again, everyone, and thank you, Nicola, for your kind introduction. I'm really thrilled to be part of this event, and I would like to thank the European Respiratory Society for inviting me as a representative for the French-speaking society. The presentations before the break were incredible, and I'm really looking forward to hearing now from so many experts on COPD. I'm sure that the next talks will be as exciting as the first. Thank you.
Yeah, we definitely they will be. I'm quite confident. Now we have Florin Mihaltan, who is from the National Society of Respiratory Medicine in Romania. And Florin is also the head of the Pulmonary Clinic 3 at the Institute Marius Nasta in Bucharest. He's a member of the Commission for Clinical and Epidemiological Management of COVID-19 with the Ministry of Health of Romania, future president of the Romanian Society of Respiratory Medicine, and last but not least, elected president of the ENSP, which is the European Network for Smoking and Prevention of Tobacco. And Florin, nice to see you again with us.
Hello to everyone. Thank you, Nicolas, for the introduction. Of course, this chapter COPD is a challenging chapter for all. And I'm very glad to see so many experts together. And all my colleagues are impatient, waiting to see what are the new knowledges and the new strategy in this disease.
Thanks, Florin. And last but not least, we have from Greece, Dr. Nicoleta Rovina, who will be the national chair for the Hellenic Thoracic Society. Nicoleta is associate professor in pulmonary and critical care medicine at the National and Capodistrian University of Athens. She's also a research collaborator of cellular immunology in the Center for Basic Science Science in the Biomedical Research Foundation of the Academy of Athens, and that is since 2019. Nicoletta, nice to see you again.
Thank you very much for your kind introduction. It's a great pleasure to be participating in this marvelous event. It's like a science festival, if it is allowed to be expressed like that. But I think this second part will be as fascinating as the first part. Thank you so much.
Thanks to you all. Nice to be with you.
Just to orientate you, the ERS satellites was launched in 2018 with the simple aim to provide cutting-edge education on important clinical topics for healthcare professionals worldwide. So in effect, it's an international clinical meeting delivered with sustainability in mind. And to that end, there are actually 3,000 participants from 130 countries registered and partaking in this meeting as we speak. Over the day, we're covering 4 topics: pulmonary hypertension and pulmonary embolism, COPD, ventilation and asthma. And within each one of these sessions, our speakers have been asked to cover the topic under some themes. One will cover disease mechanisms, another will cover the state-of-the-art treatment approaches, there'll be a clinical perspective, and finally a horizon scanning approach. And that way we really cover the topic from beginning to end. Now, you're very important as participants online. So your interaction is not just needed, it's welcomed, and we hope that you can participate. So please do put your questions to the speakers on the virtual platform. And do interact when there's polling questions. And finally, remember to complete the survey at the end so that you can get your CME credits. Replays of this event will be available on the ERS channel. Now, the ERS channel is something that we at ERS here have been working on developing for some time. I think you're going to really like it. It's got a lot of different media formats with online content covering podcasts, panel discussions, interviews, and even some documentaries. As you've heard, this event is endorsed by several international societies, the Hellenic Thoracic Society, the Romanian Pulmonology Society, SEPAR, and SPLF. And we're also really deeply appreciative of the financial support given as a grant with full discretion by our partners, AstraZeneca, Chiesi, GSK, Pfizer, and Sanofi Regeneron. And we're deeply grateful to them for this sponsorship. And so without further ado, we'll move on to COPD.
ERS is a founding partner of the International Respiratory Coalition, known the IRC. The IRC aims to transform respiratory outcomes in the post-pandemic world by supporting countries to implement national respiratory strategies based on best practice. It aims to reduce deaths from respiratory diseases, including COPD, by a third in 2030. The IRC is developing a range of tools to support countries to form national-level groups, develop plans, and to advocate for much-needed change. Use the IRC's Lung Facts tool to access the latest epidemiological and economic data on COPD per country across WHO Europe. Okay, so now we're going to jump into this COPD session. I'm really excited. As some of you know, it's a topic I really like. So let me first introduce our first speaker, who is Rosa Faner. Rosa is the group leader at the Department of Biomedical Sciences at the University of Barcelona. And she's also, very importantly, a member of the management committee of the ERS CRC clinical research collaboration called CATSET. And Rosa is going to talk about a very important topic these days, which are the early life origins versus accelerated decline forms of COPD. Are these the same? How are they different? Well, Rosa, the floor is yours.
Thank you for this introduction. And as said, I've been given the challenging task, despite all these unknowns, to try to define what are the similarities and differences between the early life origins of COPD and accelerated decline. And to do so, this is the outline that I will follow. At first, I would give a brief introduction of the many phases of COPD, and then concentrate on the phenotype, aging biomarkers, and genetics of abnormal growth versus accelerated decline COPD. And finally, move to wrap up all the talk. So very briefly, as all of you know, COPD is a prevalent disease, a leading cause of mortality, still diagnosed with spirometry in the appropriate clinical context, but importantly, the mean age of diagnosis is 65 years of the patients. It's heterogeneous biologically, pathobiologically, and clinically. Some patients have chronic bronchitis, others emphysema, mix of those, different symptoms, exacerbations. Many risk factors, tobacco smoking being a prominent one, also infections, a genetic susceptibility, and these early life origins in which we have exposition since in utero associated to the later in life development of COPD. Very briefly, which are the key unmet needs in this field is to move towards an earlier diagnosis in young individuals to better understand this complexity and heterogeneity, and move towards a better understanding of the mechanism in order to be able to cure the disease. So now we know that in fact there are different vital lung function trajectories associated to the development of COPD later in life, starting from from birth in conception, with this traditional paradigm of normal peak lung function with accelerated lung function decline associated to smoking and an abnormal inflammation is present in about 50% of the individuals with spirometrically defined COPD in its 6th decade of life. On the other hand, between 4 to 12% of the general population have this abnormal peak lung function, which is in early adulthood, that may lead to COPD later in life without an accelerated decline or with an accelerated decline. So this is why I said it's a challenging task, like to identify accelerated decline from abnormal or early life origins, because it can be both a mixture of early origins plus accelerated decline. However, what we now know is that in general, there are these lung function growth trajectories, some of them the ones that are above the normal range, or even this lung growth failure have been recently associated with inflammatory processes. While on the other hand, traditionally, after the peak lung function, this presence of COPD has been associated with these so-called hallmarks of aging. What are the hallmarks of aging? Are these 12 different processes that occur in the cells that the group of Carlos López-Otín in 2013, now they have just launched a new revisited version of the hallmarks of aging, describe that happen in all the cells as they age. And it's not usually, it can be correlated with chronological age, but it's a marker of the biological aging of the individual. And I will be referring of what evidences we have of accelerated aging in this accelerated lung function decline or in relation to this abnormal peak lung function. In clinical, several terms have been emerging to move towards an earlier diagnosis. And here I want to specifically introduce this term young COPD, as I will be using it to refer to those individuals that are younger than 50 years of old, but they fulfill the clinical definition or the gold clinical definition of COPD, while I will use the term old COPD for those individuals that have more than 50 years of age and fulfill the clinical definition of COPD. So what we know about old COPD? So many studies using clinical variables have been a variety of clustering methods and identified several phenotypes of patients. We know that some patients with old COPD have persistent inflammation, comorbidities, coexistent with asthma, emphysema, exacerbations, and high eosinophil counts and a genetic background. Many efforts have been trying to identify biomarkers of these individuals with old COPD. If we have a look from 2000 to just last year, the number of papers published in PubMed, you will see the rise of number of studies in biomarkers. It's very difficult to summarize that in one slide, but I would say that most of the studies use patients with COPD or with a mean age of 65, have described sputum neutrophils, change levels of eosinophils, whole blood counts, inflammatory markers like CRP, adipokines, associated with smoking, emphysema, change of FEV1 exacerbations, but also pneumoproteins like CC16 have been in several and reproducibly associated with smoking, emphysema, and this poor lung function. So we know that it's heterogeneous clinically and biologically. There are also papers that have been trying to use this clustering of different, measuring different biomarkers and clustering the biomarkers in groups, and then comparing how these different clusters of biomarkers now relate to the clinical characteristics. So these works are showing us that it's not just one biomarker, it's a signature of different biomarkers that is, for example, associated with the presence of cardiovascular comorbidity. If we now want to translate this knowledge to what is in young COPD, very few cohorts of young COPD are currently available or are still under development. But I want to show you some briefly work that we did in our early COPD cohort in Spain that includes 100 patients that are younger than 50 years of old and 200 smoking controls. Of course, they fulfill the definition of COPD. They have a variety of FEV1 levels. So some have more impairment and the airflow limitation than others, and present different degrees of DLCO. But importantly, about 63% of these young patients with COPD recruited from tertiary hospitals presented emphysema in the CT scan, about 60%, while I would say also surprisingly, 20% of these young controls, smokers, presented also emphysema. If we want to summarize all these in one network, what we can see is this young COPD is associated with impairment in the functional domain, but as in all COPD, with whole blood counts, low education levels, smoking, and visits to the GP at an earlier age. Interestingly, the well-established COPD cohorts like Eclipse or COPD gene had an inclusion criteria that was older than 40. So we can use, they included some patients that fulfill the definition of young COPD. And if we compare these three cohorts, the one in Spain and these other two cohorts that are international, we see the same. Patients with young COPD have, from the clinical setting, have impaired lung function, presence of emphysema, and some blood biomarkers, suggesting that these patients from this same setting have similarities at the phenotypic level. But if we now move to earlier in time, so if we want to see how are these young individuals, 25 to 35 years of age, with normal or abnormal peak lung function in relation to these clinical characteristics and biomarkers. I just want to show you this recent study that we did in collaboration with the LifeLife cohorts. And these 300 individuals were selected and matched by smoking, so we cannot explore the smoking status. But I just wanted to draw your attention that individuals with a low level of FEV1 in this early adulthood have a shorter tendency to shorter duration of pregnancy, but importantly, they have wheezing, they have abnormal lung function, they were matched to have no difference in the diagnosis of asthma. But if you remember some of these biomarkers that just show you a couple of slides before related to COPD at age of 65, like low levels of CC16, rage, and some inflammatory markers, if we now measure them in these low peak lung function individuals, what is interesting is that these individuals that don't have COPD, they only have for now an abnormal peak lung function. They present abnormalities in the same biomarkers, in the same direction of effect, that when they are included in the regression model, they add to the classification of these patients with the level of lung function. But interestingly, here we measure two aging markers, the telomere length and the mitochondrial DNA, and those were not associated in these young individuals. So, as said, usually after the peak, COPD is associated with an accelerated aging. Some examples of that, one of the hallmarks of aging are the differences in the level of methylation. So in lung of patients with well-established old COPD, what we do see is in general hypomethylation, one of these hallmarks of aging. Some studies are now showing using what is called these biological clocks that use some of these CPGs to predict the age of the individual. So some studies have shown that patients with old COPD, both in the airway epithelial cells or in the blood, have an acceleration or an accelerated aging measured using these aging clocks biomarkers. So what do we know about aging, accelerated aging in young versus old COPD? Again, very little, but some preliminary studies also show that in this young population of COPD versus this old population of COPD is the level of airflow limitation associated with shorter telomeres. So it's aging in relation to accelerated aging in relation to the severity of airflow limitation in both age ranges, so independently of the age of the individual. We did not see the same for the level of DLCO, likely because of the small sample size of the young COPD cohort, but more studies on these aging biomarkers in younger individuals are warranted. And about genetics, this is the latest COPD GWAS that was published several years ago and identified some new loci associated for COPD. But interestingly, they found some SNPs associated with lung development, supporting the role of early life events in the risk of old patients with COPD. But what is more interesting is if they use these genetic biomarkers combined and produce a polygenic risk score, which captures the information of all the genetic variants in one single measure, this polygenic risk score of COPD is associated with the age of diagnosis of COPD, meaning that young individuals on two different cohorts, this is on COPD gene and the other is on Framingham, the polygenic risk score is associated with the earlier age of COPD diagnosis, incident COPD. And here you can see that even if you use to model to discriminate patients with COPD, just using the polygenic risk score or clinical variables or in combination is a combination of both the polygenic risk score with the active smoking status, the childhood asthma, and the family history, what builds the best model to identify these individuals. So in summary, we have proposed that COPD is a disease that has early life origins. Is it the same or is it different to people with accelerated lung function decline? It is complementary. It can be a second hit. But we do really need to understand what happens to the individual across its whole lifespan and to know which are the different exposures to which it has been exposed in order to understand which is the balance between the injury that it receives, the capacity of the individual to repair this injury, and how it affects long-term to its genome captured by its epigenetics, in order to understand which are the factors that are associated to the level of FEV1, FEBC, presence of COPD at different age ranges, and know that as earlier as we can intervene or diagnose would be better, because the interaction in the number of associated factors increases with the age, and making it more difficult to really intervene if we move to the 60th decade of life. So in conclusion, the summary of the talk is that a life course perspective is needed to understand COPD, that young and old patients with COPD from the same setting, then just keep in mind that our patients were both from a hospital setting, not from the general population, shares phenotypic characteristics, that some of the well-established or old COPD biomarkers are already able to identify those individuals with an abnormal peak lung function, even not having yet COPD, that accelerated aging has a role in the severity of the disease, independently of the age of the individual, and the genetics of all COPD have also been related to an earlier age of onset. And with that, I want to finish. I want to thank you for your attention, and I will be happy to have questions. Thank you.
Rosa, thank you so much. That was a fantastic talk, and I'd say there's going to be lots of questions about this. It's really fascinating how this field has moved on in such a short time. We're going to move on to our next speaker, who's Professor David Halpin. David is a consultant chest physician and a professor of medicine at the University of Exeter and an honorary professor at the OPRI. And importantly, he's also a member of the GOLD committee, particularly the science part of GOLD. David is going to talk about the link between biology and behavior. David, I'm really looking forward to this talk. Thank you so much for joining us. It's a great pleasure to have you, and I'm sure we're all going to enjoy this talk.
Well, thank you very much, Richard, for that introduction, and thank you, Nicola, as well, for asking me to speak at this meeting. I have to say I was a little thrown by the title when I first saw it, but I've interpreted it as that all patients with COPD are different, and we have biological differences and we have behavioral differences, and all of those factors need to be taken into account when we make management decisions. So what I want to do over the next 20 minutes or so is just try and flesh out what we have recommended in the latest GOLD report and how that would relate to clinical cases. These are my declarations of interest. And as I said, much of what I'm going to talk about will center around the 2023 GOLD report. And as I'm sure you all know, this is freely available to download from the GOLD website. So following on from what Rose has been talking about, when we make a diagnosis of COPD, we have three things to consider. We have the relevant symptoms, and in the 2023 report, we spell out the key symptoms for COPD, which are breathlessness, cough, and sputum. And we have an exposure to a risk factor. And what the work that Rose has been talking about has led us to understand is there are much broader risk factors than just tobacco smoking. And if you have a patient with symptoms, with risk factors, you then need to confirm the diagnosis with spirometry. And that's been a challenge during the pandemic, but I think we must emphasize the importance of performing spirometry to define COPD, because as Rose has pointed out, all our evidence about management comes from populations that have been defined using spirometry. So I want to use a few hypothetical clinical cases to talk through the issues. So this, and I'd like you to imagine that you're in a specialist clinic with all of these patients. This is a patient who's been referred, he's 57, he's breathless, he has a chronic cough, he used to smoke, he's still working full time, there's no history of asthma or previous respiratory disease, but his primary care practitioner has started him on a dual bronchodilator inhaler, a dry powder inhaler. When you see him in your clinic, you perform spirometry and you see that his FEV1 is in the normal range and his FEV1 FVC ratio is also normal. You check his symptomatology using the CAT score, which is high, so he has a high burden of symptoms, and he's somewhat overweight with a BMI of 28. So the questions I would have in clinic are, what are the treatment objectives? What are we trying to do here? What are your treatment options? And what, in fact, would you do in practice? So for me, the key issue here is establishing the diagnosis. Does he have pre-COPD, as Rosa's mentioned briefly? Does he have other conditions such as heart failure that are causing his breathlessness? So a differential diagnosis and establishment of the diagnosis, I think, is crucial. We know from his spirometry, even if he has pre-COPD, he doesn't meet the current criteria, and therefore I think it's important to stop his bronchodilator therapy. There is no evidence for benefit in this group of patients. The recent RETHINK study published in the New England Journal shows that patients who are breathless but don't have the spirometric abnormalities are not going to get benefit from dual bronchodilator therapy. And I would encourage him to take exercise, and I'm sure Thierry will be talking more about the importance of exercise in the next presentation. So if we look at what we say in the Gold Report about pre-COPD, we talk about the fact that this has been recently proposed as a term similar in some ways to the Goal Zero that we used to have, to try and raise awareness that these people may go on to develop COPD. Not all of them will, but some of them will, so they need monitoring. And we refer to this paper that was published by some members of the Gold Scientific Committee in the Blue Journal in 2021. And again, if you'd like to know more about current thinking, I'd encourage you to read this. The key reason for pushing pre-COPD relates somewhat to what Rosa was talking as well. And this is a schema taken from the Lancet Commission paper. At the top, you can see a sort of summary of where we have been for the last 30, 40 years in terms of COPD management. The diagnosis is only made when the level of symptoms becomes significant. By that time, there's been significant loss of lung function, and the opportunities to intervene and to make a difference to long-term outcomes is limited. At the bottom, you can see that if we could make the diagnosis of COPD earlier, at the earliest onset of symptoms, when lung function is still well preserved, there's a much better opportunity to intervene with things that may change the natural history of the disease, leading to slower decline in lung function and ultimately also reduce mortality. So that's why early diagnosis and early identification of patients really matters. When we talk in Gold about that initial assessment, spirometry is important, as we've just discussed in terms of making the diagnosis. But for a patient, in more general terms, it's important to think about the nature of their symptoms, whether they've had previous exacerbations, whether or not those have been actually recognized as exacerbations, and also the presence of other diseases. And we're developing, alongside the sort of thinking that Rosa's been talking about a much broader etiology of COPD, we now recognize the importance of other comorbidities in COPD. So when we come to make the diagnosis, make the assessment, we still have the 3 steps that Gold recommends. We have the spirometry to confirm the diagnosis with a post-bronchodilator ratio less than 0.7. We can then assess the severity of the airflow obstruction using the Gold stages 1 to 4. But then we move on to the clinical assessment. And we retain the parameters that we've recommended before, the level of symptoms as determined by either the MMRC score or the CAT scale, and also the risk of exacerbations based on the history of exacerbations in the previous 12 months. So if a patient is at low risk of exacerbations because they've had just 0 or 1 moderate exacerbation in the previous 12 months, depending on the level of symptoms, they may be in group A with low levels of symptoms or group B with higher levels of symptoms. If, on the other hand, they're at a higher risk of exacerbations because they've had 2 or more moderate, or they've been hospitalized for an exacerbation in the last 12 months, they now go into a single group E for exacerbations, irrespective of the level of symptoms. And their management, their initial management, depends on whether they're in one of these 3 groups, A, B, and E. We've merged the 2 groups C and D into the single E. But as well as that assessment, it's important to remember that we need to look for these comorbidities and not just focus on the airways disease. And as you will know, Some of these conditions share risk factors such as smoking or aging or inactivity, but there is evidence that they are pathophysiologically linked to some of the inflammatory mechanisms that are present in COPD or to things like hypoxemia. And so when we think about a diagnosis of COPD, we should also be thinking actively, does the patient have cardiovascular disease, heart failure, ischemic heart disease, and arrhythmia? Do they have diabetes or metabolic syndrome? Do they have osteoporosis? And very importantly, I think, do they have anxiety and depression? We're probably quite good at picking up the cardiovascular disease. I think we're much less good at picking up the psychological aspects. So let's think about another patient. This is a patient, again, a 58-year-old man who's now been referred to your clinic, who's had no previous therapy, no previous diagnosis. He gives a history of having had 3 what he calls chest infections in the last 12 months. He's breathless climbing a flight of stairs. He is still smoking and has accumulated 60-pack years altogether. He's somewhat overweight. He's known to have type 2 diabetes and depression, and he's not worked for the last 10 years. Again, you do some investigations, you find that he's got significant airflow obstruction, his FEV1 is 55% predicted, he's got a ratio of 0.6, his CAT score is 22, and his blood eosinophil count, you know from his general medical records, is 320 cells per microliter. So again, the same questions: what are the treatment objectives, what are the treatment options, and what would you do? So for me, we need to think about the GOLD treatment objectives. There are the initial objectives of reducing symptoms, improving exercise tolerance, and improving health status. But we also need to think long-term about preventing disease progression, very importantly, preventing and treating exacerbations, and ideally reducing mortality. So for Pete, the objectives of treatment are to reduce breathlessness, exacerbations, and reduce his risk of death. Clearly, smoking cessation is fundamental in a man like this. It's important that also he tries to address his weight and takes exercise. And again, I'm sure Thierry will talk about that. He would meet he meets the diagnostic criteria for COPD. So we think he's got COPD now as well as his other diseases. And the treatment for that, the pharmacological treatment, could either be dual bronchodilator therapy or triple therapy. I'll talk about that in just a second. He's got COPD, so pulmonary rehabilitation, I think, is appropriate given his level of breathlessness. We would want to make sure that his depression and diabetes were optimally managed, and we might want to consider an echocardiogram to see whether he's got heart failure as well as the hypertension. And as part of his basic management, we'd also want to vaccinate him. So in the new GOLD report, we make recommendations about the initial management based on the classification into groups A, B, or E. In this man's case, he would fall into group E because he's had these 3 exacerbations in the previous 12 months. And we could recommend either dual bronchodilator therapy. But if his blood eosinophil count is high, we've made a practical recommendation that you could, as first-line treatment, consider triple therapy in a man like this. And I think in his case, even though he's got diabetes, I would think he would benefit from the addition of the ICS to the dual bronchodilator. As the disease progresses, we have this sort of circle of management. So we make the initial diagnosis, we make the initial assessment, and then we move on to the initial management decisions. And that involves pharmacotherapy, as I've just talked about, but also importantly, non-pharmacological things like smoking cessation, like vaccination that I've mentioned, self-management education, encouraging exercise. And then we move into a cycle of review and adjust, where we would review the symptoms, whether they've improved, review the response to our advice. Is he still smoking? Has he been able to take exercise or not? And as time goes on, assess other things such as the need for oxygen therapy, ventilatory support, which I'm sure will be covered after lunch, and so on. If there is a need, then treatment needs adjusting, and then a cycle of review and adjust continues. So let's now think about June. She's a little bit older. She's 62. She's still breathless when walking upstairs. She was a smoker, but fortunately has stopped. She's still working full time and has had no exacerbations in the last 12 months. She had been prescribed an ICS-LABA in a PMDI. So she comes for review in clinic. Her spirometry is pretty bad. Her FEV1 is 45% predicted with a ratio of 0.55. Her level of symptoms is actually quite high with a CAT of 23. And I think this is an example of how using an objective measure like CAT can be really helpful, because talking to her, it would appear the only limitation is she's a bit breathless walking upstairs and she's still able to walk. But when you look objectively at her symptoms using a measure like the CAT, you can see she's got quite a high level of symptoms. Her blood eosinophil count is low at 80, and when you check her inhaler technique, it's poor. And as you know, for whether it's asthma or COPD, checking inhaler technique at every review is vital, because a patient is not going to get a benefit from their inhale therapy if they're not able to use their device correctly. So again, the question would be, at this review meeting, what are your treatment objectives? What are her treatment objectives? This needs to be a shared decision. What are the options, and what would you do in practice? So I think with her, the key aim is to improve breathlessness and improve health status to try and reduce that CAT score. I would say that she is inappropriately treated with an ICS-LABA. Whether she was appropriately treated in the first place, according to recommendations at the time, we can't say. But now she's had no exacerbations in the last 12 months. She's got an eosinophil count of less than 100. There is no indication for an inhaled steroid. She is breathless, and therefore I would change her to a dual bronchodilator therapy. She's not able to use the PMDI appropriately, so I would also change the device to one that she can use. I would be looking for comorbidities to see whether there's anything else contributing to the breathlessness and the CAT score, again, such as heart failure. And I would encourage her to take exercise. So this is part of the goal cycle of review, assess, and adjust. We're looking at her symptoms. We're looking at how she's responded to treatment she's been established on. We're making treatment management decisions based on that assessment. And you will know that in GOLD we have these two algorithms for the follow-up management, depending on whether the principal problem is breathlessness or whether it's exacerbations with or without breathlessness. But before we jump into the algorithms themselves, there is an important box which asks us to check that the response, if the response to treatment is not appropriate, that we look at things like the adherence to medication and the inhaler technique, and also that we look for comorbidities that might be contributing. So before we make the knee-jerk reaction of saying we need to change the inhaled therapy, we need to check that the patient has been using their current therapy appropriately and that that therapy is appropriate. So in her case, the principal problem is breathlessness. She's not had any exacerbations. She was on LABA ICS, so we would recommend in GOLD changing that to dual bronchodilator. And if she continued to have problems, then we have the option of changing the molecules, the device, looking for other causes of breathlessness, and thinking very importantly of non-pharmacological approaches such as exercise. Let's move on to another patient, Fred. He comes for review. He's breathless walking up hills. He's stopped smoking but still working. He has hypertension, but he's had 2 exacerbations in the last 12 months. So he has both breathlessness and exacerbations. He's been treated with dual bronchodilator therapy. When you assess him, he's got airflow obstruction. His CAT score's not too bad at 19, but it is still up. And he's got an eosinophil count of 220. When you check his inhaler technique, he is able to use his inhaler quite well. So again, the same questions. What are the treatment objectives? What are the options? What would you do in practice? So for him, I think we have the dual aim of trying to reduce his breathlessness and exacerbations. That would mean, to me, adding an inhaled steroid and giving him all 3 drugs in a single inhaler. I would be looking again for comorbidities. He's got hypertension. Has he developed heart failure to contribute to his breathlessness? Encouraging exercise and pulmonary rehab, and making sure that he's had his vaccinations. So he fits in the right-hand box here, where his problem is both exacerbations and breathlessness. And you can see that we have different thresholds for escalating. He was on dual bronchodilator therapy. So in his case, in the middle there, you can see that if his eosinophil count is above 100, then GOLD would recommend escalating to triple therapy. And you will be familiar, I'm sure, with this traffic light diagram in the GOLD report, which talks about indications for inhaled steroids. We have features that strongly favor use, which are either more frequent or more severe exacerbations, higher blood eosinophil counts above 300, and obviously, if there was a history of asthma or there was concomitant asthma, we no longer talk about ACO in gold, but if the patient has two diseases, asthma and COPD, then there'd obviously be an indication for inhaled steroids for that reason. At the bottom, we have features that are against the use of inhaled steroids, repeated pneumonia, eosinophils less than 100, or a history of mycobacterial infections. And in the middle, we have a group which has previously, I think, been thought to be a group that is not going to get as much benefit from inhaled steroids. That's not the case. The patients will benefit, but it's just other things could be done first, such as dual bronchodilator therapy. So in that intermediate group, if despite ongoing treatment, a patient's had one or more moderate exacerbation or has intermediate eosinophils between 100 and 300, that would still favor the use of inhaled steroids. And the reasoning for that comes from the two big studies that have looked prospectively at eosinophils and the addition of inhaled steroids to dual bronchodilator therapy, the impact and the ethos studies. If we strip out the LABA ICS arms and just look at the difference between the triple therapy and the dual bronchodilator therapy, you can see on the right-hand side in both these graphs at eosinophil counts above 300, there's a clear separation, so undoubted benefit from adding the ICS. There is still a benefit above 100, but there's some overlap of the confidence intervals. And that's why it's worth trying other things first. But if, despite those other things, such as dual bronchodilator therapy, the patient is still having exacerbations with an eosinophil count of above 100, there will be a good chance of benefit from ICS. So thank you for your attention. I hope I've tried to flesh out some of the biology and behavioral factors in patients with COPD that influence those treatment decisions and tried to illustrate how the recommendations in the GOLD report can be used in practice. So thank you for your attention.
Well, thank you very much, David. This was really enlightening. I think it's very nice to see how you integrate the recommendations from GOLD into clinical practice and how you think about it to personalize treatment based on both the biology and the behavior. That was really nice. Well, now we are going to Professor Thierry Troosters, who is a physiotherapist heading the rehabilitation science in Leuven University in Belgium. Thierry is well known by all of you, I believe. He has been president of the European Respiratory Society only a few years ago. And of course, Thierry is going to address the issues about rehabilitation and specifically in the real life. So again, this is certainly going to be a very practical talk. So Thierry, very, very nice to have you on board with us. The floor is yours.
Well, thank you, Nicola and Richard, for the kind introduction. And it's indeed a pleasure to give this talk about a topic that I'm passionate about for the last 30 years or so. So it's really a pleasure. And let me also start with a case report. And my John is slightly obese, has moderate COPD, has significant symptoms, as you can see from the MRC score, and was admitted to hospital and is now receiving continued treatment or a continuation of his treatment for a severe acute exacerbation. John needs rehabilitation, and I'll try to convince you that this is the case. Otherwise, I wouldn't have a talk today, but he needs rehabilitation. But then the clinician is faced with the questions, well, why is this needed? What is this going to do for John? How long should it be? Where should it be? And John may also have questions about it that he will ask his clinician. And that's what my presentation will be about. What is the place of pulmonary rehabilitation? I was really happy that David already alluded to rehabilitation a couple of times in his presentation. What can we expect and what can John expect from a rehabilitation program? And then he'll be convinced that he needs rehabilitation. How do we then anchor rehabilitation in the care trajectory? And then maybe a reality check, because rehabilitation may be nice on paper, but it needs to be implemented. And that, I think, is where the biggest challenge for us lies today. But first of all, let us get some clarity on some of the terms that are used interchangeably by many of us. People think about or speak about physical activity and about exercise training or pulmonary rehabilitation, and it sort of goes all into the same melting pot. And these are really distinct things. physical activity is actually everything you do on a regular day. So if you walk to your office, that is physical activity. And probably now you're not very physically active. So I would invite you to stand up and maybe walk around a bit and then continue listening to the presentation. It's actually good for your health. Exercise training is something else. It's more purposeful. It's like an intervention. It comes with a given dose, it comes with a given frequency, it comes with a given duration. And as it is a medicine, so to speak, if you stop, you will lose the benefits of it, much like a bronchodilator. A long-acting bronchodilator will work a bit longer, but if you stop it, the effects will wear off. It's the same with exercise. If you stop exercising or exercise training, you will lose the benefits of that intervention, that treatment that we can offer our patients. And then you have pulmonary rehabilitation, which is an individually tailored program that consists of exercise training. So exercise training is an essential component, but rehabilitation is more than that. It offers the patients the tools to then go on with his life and seek exercise training on his own, make sure that it tackles all the different treatable traits, that patients can quit smoking if they're still doing so, that they resolve social issues, mental health issues, and so on. And the idea of rehabilitation is that it goes after an improved physical and mental health, and that patients adhere better to long-term health-enhancing behaviors that David already alluded to earlier on. So they are sort of interlinked, but slightly different concepts, and I don't think we should confuse these concepts. So where do these sit within the management of chronic obstructive pulmonary disease? Well, since David already used the GOLD guidelines, let me take them as sort of a blueprint, and you will see that after the diagnosis and the initial assessment of your patients, and you will see the same measurements as the ones that David already mentioned, advising an active lifestyle, advising exercise and self-management, also components of that rehabilitation program, are very early on brought to the patient as part of the initial management. And if then that doesn't seem to resolve all the symptoms of the patient, we may have to adjust the pharmacological and also the non-pharmacological therapy. And a patient in whom you have advised to do more exercise or physical activity may then be engaged in a full rehabilitation program. So it is really an integral part of what we can offer patients with chronic obstructive pulmonary disease. And that is where we need to go to as clinicians. Not only think about pharmacotherapy, but also tackle these non-pharmacological treatments. And rehabilitation is definitely one of those. What can John then expect from such an intervention? Because it is a time-consuming intervention. You need to do it at least 3 times per week. This needs to go over a number of weeks and perhaps even months. So what do you buy for it? What sort of value for money do you get? Well, pulmonary rehabilitation really improves patients dramatically. The Cochrane review that was done on rehabilitation is even close. They said, look, we're not going to add further studies to this. Rehabilitation works. Looking, for example, at the effect of rehabilitation on the 6-minute walking test, you see across all the studies that there is about a 40 to 50 meters improvement in the 6-minute walk, whereas only 30 meters improvement constitutes a clinically important benefit. Looking at exercise endurance time, you can see that bronchodilators in the middle graph improve the constant work rate endurance time significantly. But if you contrast that with exercise training, you see that the effects of exercise training really outweigh the effects of any other intervention that we can give our patients with COPD. Now, obviously, patients that undergo exercise training, and particularly pulmonary rehabilitation, will be on optimal pharmacotherapy. So we shouldn't compare these bars with each other. But you can clearly see that when you engage in exercise training, the effects are even better than just with pharmacotherapy. And if you step the therapies up, if you want, if you start from just giving a patient advice on physical activity, which is in the right side graph, the placebo group, and then start giving the patient a single bronchodilator, a dual bronchodilator, or add exercise training to this dual bronchodilator therapy, you see that there is a clear stepping up of the effect in terms of improved exercise endurance time. So this is an intervention that clearly adds something to what we can offer patients with chronic obstructive pulmonary disease. Looking into a large group of patients that we've offered rehabilitation here in the Leuven Center, you see that 65% of patients improved their exercise, their functional exercise capacity to a clinically meaningful extent. And very few patients actually have no benefit of rehabilitation. And for the sake of this presentation, I plotted two interesting outcomes from a patient perspective: functional exercise capacity on the x-axis and health-related quality of life on the y-axis. And you can see that actually 85% of patients that we offer rehabilitation will benefit from that rehabilitation to a clinically meaningful extent in one or even both of these axes. So it is really a potent intervention that we can offer our patients. Going further in the literature and in a 20-minute talk, I don't have time to discuss this at great length. Outside of improving exercise capacity in our patients and health-related quality of life, we also know that we significantly improve symptoms. We give patients the confidence back that they can actually engage in physical activity and do something. And in those patients that have mental health issues, and that's 30% of the patients that you're taking care of, suffering from anxiety, depression, or the combination of both, we will have meaningful improvements in these mental health problems. In John, who suffered from an acute exacerbation, there will be an improved survival, and the readmission rate is also significantly reduced. And there are several systematic reviews that suggest this. And there is an even better chance of improving the 6-minute walking distance, the functional exercise capacity. And taking all the studies together that have offered rehabilitation in patients like John after a severe acute exacerbation, you see that the benefits then are 77 meters, which is almost twice of what we find in patients that were stable at the beginning of the rehabilitation program. So absolute reasons to give patients with COPD to offer them a rehabilitation program. There is perhaps one blind spot in the effects that we see with rehabilitation, and that is the effect of conventional exercise training on physical activity. You would hope that if you offer a patient an exercise training program or even a full rehabilitation program, that your patients will then automatically also become more physically active. And that's not going to happen. And that is because exercise training is geared towards improving the patient's physiology. It's not geared towards changing the patient's behavior unless you offer the patient also behavior change interventions. And if you look across the literature, many of us have looked at it. And the black bars here on the graph are studies that showed a significant improvement in physical activity levels. The hatched bars are studies where this significant improvement was not found in physical activity. So if you want to change a patient's physical activity, you really need to specifically address this in the rehabilitation program of the patient. An exercise training program is not going to pull the trick. So then, how do we anchor rehabilitation and rehabilitation approaches in the care trajectory? Let me give you three sort of things to think about. The first is to give the right patient the right program. And in the center of this slide, I plotted some data from our center. On the right-hand side of the slide, you see 3 other studies that have done a similar exercise, and we all find more or less the same thing. What you see here on the x-axis is the functional exercise capacity, what patients can do. On the y-axis, you see what patients actually do. And these are 2 different things. It may be possible that you have a good exercise capacity, but that you're actually not using that exercise tolerance in your daily life. We would call that lazy to some extent. Then you have patients who really lack the exercise capacity to actually engage in things. And then you have a completely different problem, of course. And so if you think about interventions and offering the right patient the right intervention, if you want to improve the patient's exercise tolerance, what you need to offer that patient is to offer him optimal bronchodilator therapy so that the patient can breathe as much as possible, and then also improve the rest of that patient's function by offering the patients an exercise training program. And then what you do is you move patients from left to right on the graph. They become stronger, they get a better exercise tolerance. Their physical fitness will be improved with exercise training, and I've shown you the evidence before. But if you then also want to make patients more physically active, you now want to move them from the bottom of the graph to the top of the graph. It doesn't take an exercise training program. It actually requires a change in behavior. Patients need to actually go out and about, start walking again in their daily lives, and they need specific interventions that are geared towards that behavior change interventions. An example would be to give a patient a step counter and give him or her a goal to achieve every single day and agree on that goal. Try to achieve 5,300 steps the next week, and then slowly build that up so that patients move from the bottom of the graph to the top of the graph that you see in the middle of your slide. Now, by offering patients such a behavioral intervention, they may become more active, but it's not necessarily, or it's not going to change their physical fitness. So changing the fitness from left to right requires a training program. Changing from the bottom to the top of the graph requires a change of behavior, a different intervention. A second thing that I wanted to address in this 20-minute talk is that you need to address the full scope of the patient's problems and target as much as you can the different treatable traits that we have in patients with COPD. And here you can see an investigation literature search that Anne Holland did with her team. And what she found was that the vast majority of studies that looked into the literature at what they would actually target with their rehabilitation program is the deconditioning that you see on the left-hand side on the slide. Almost all rehabilitation programs will try to improve the physical fitness of patients. But other treatable traits like nutritional problems or mental health issues are not really picked up in many of the rehabilitation programs that we offer our patients, at least not the ones that we find in literature. And here I think there is still some stretch in what we can offer to patients. Also, when we go to behavioral change or lifestyle traits, you can see that physical activity is not really targeted in many of the programs. Smoking cessation is not really a target in many of the rehabilitation studies that were published. And for example, non-adherence to treatment, also an important element in getting the full benefits of the interventions that we offer our patients, is only sort of covered in about half of the rehabilitation studies that were published in literature. And so here I do think that rehabilitation teams can do better in targeting all the extra pulmonary treatable traits in our patients. And they actually do exist. And this is work from Portugal. Alda Marques's group looked at it. And you can see that many patients suffer from dyspnea. Many patients suffer from mental health problems. I said about 30% of patients, and that's also what is found in this specific study. So if you're setting up a comprehensive pulmonary rehabilitation program that goes outside of the box of just looking at exercise and muscle function, you really need to integrate things that will also cover problems with depression, with anxiety, with the low functional capacity deconditioning, but things also like poor balance that provide patients with a risk of falling. And that is also something that could be tackled in a full rehabilitation program. Looking at our patients, and this is just an example, you can see that about half the Belgians that we see in our program have no nutritional issues, at least not from the perspective of their body mass index and their fat-free mass index. But the other half of patients are either obese or cachectic or have a low fat-free mass, and this requires specific interventions that help patients to either lose or gain weight, change their fat-free mass, for example. As I told you, a large amount of patients will suffer from anxiety, depression, or even the combination of anxiety and depression. And again, these patients may require some more psychological interventions as part of their rehabilitation program. And the vast majority of patients is actually inactive and requires some help in regaining physical activity once they go through a rehabilitation program. It's also important to note that these programs should not abruptly stop. Typically, rehabilitation or sometimes rehabilitation is offered as a package for a couple of weeks. In fact, there should be some continuation, particularly of the exercise training component. If you stop the exercise training as a treatment, the patient will lose the benefits of that treatment. And so it's good to foresee that when your program stops, there is a continuation of that program in clinical care so that patients once a week, for example, can do some exercise under supervision, and then the maintenance of the effect of the intervention is more guaranteed. The real problem is the problem of access to rehabilitation. Here you can recognize a few maps. You will definitely recognize the United States. You may also recognize part of the UK in the center of this slide, and perhaps you will recognize also Belgium over here. and the dots represent where you find rehabilitation. And although it looks as if there is a lot of rehabilitation available, you can also appreciate that sometimes this may be very far from the patient's residence, difficult to access. And even when patients can access rehabilitation, the program may not be prescribed as much as it should be. David, in his presentation, said this patient needs rehabilitation, but reflect on it. How many patients are you actually prescribing and sending to a rehabilitation program? And then when you've prescribed the rehabilitation, is the patient taking this option up? And you can see that less and less patients are sort of still included here. Access is not available to every patient with COPD. Less of them, about 15%, are referred, about 10% will take up the offer, and then about 70% of those will complete the rehabilitation program. We're losing too many patients along the line, and here I think lies a big challenge for us as clinicians and as a community actually towards patients with COPD. We need to make sure that rehabilitation takes different forms and shapes. And so depending on the case, John in my case, and also the patients that David presented you with, rehabilitation may require the efforts of an occupational therapist, a nurse, a physiotherapist, an exercise physiologist. It may be done in an inpatient setting for some patients, an outpatient setting, at home perhaps for some others. It will depend a bit on the type of patients that you're seeing. Is that a stable patient or a patient like John after an acute exacerbation? And also the exercise can take many forms. In some patients, more resistance training, and in some patients, more endurance or interval training, for example. And again, Anne Holland, with a team at the American Thoracic Society, has written a very nice paper during the COVID pandemic about this, on what are the essential components of rehabilitation in terms of patient assessment, the program components, the methods of delivery, and how can we ensure quality of our programs. And in blue are the things that we definitely need. In black are the things that are nice to have, and as much as possible, we should try to have them as part of our rehabilitation program. And so going through that paper, and I don't have time today to discuss this at great length with you, you will then see what you need to be able to offer. But subsequently, a program can perfectly be run in primary care, for example, or in primary care combined with second or third line care. So back to the case of John, we did some further assessment in John and found that his functional exercise capacity was poor. He also suffered from muscle weakness and respiratory muscle weakness. He had some symptoms of anxiety and depression, and he also had a lot of other symptoms. John was ventilatory limited, and we then had to design a program specifically for him, which included a lot of healthcare professionals, as you can see here. John had to take care of his grandchildren on Wednesday afternoon, and therefore could not come 3 times a week to our outpatient program. So we did the outpatient program together with 1 session in the home care setting. And we also designed the exercise training to tailor for John's specific problems. With that, I would like to thank you for your attention, and I'm waiting for your questions.
Thierry, thank you so much. That's a fantastic presentation, and I'm sure there's going to be loads of questions. It's very, very thought-provoking. And of course, in particular, I'm going to be asking you about the care of those grandchildren and whether he should stop doing this. But we'll move on to questions and answers later. The last speaker is Judith Garcia Aymerich. Judith is currently the General Secretary of ERS, but she's a fantastic clinician scientist researcher in Barcelona. And Judith is going to give us a talk on horizon scanning and COPD, what's in the future. Judith, it's great to see you. Thanks so much for taking the time to join us, and we're really looking forward to your presentation. The floor is yours.
Thank you. Good morning, and thank you for inviting me to this fascinating session. I have no conflict of interest in relation to this talk. So my talk is about horizon scanning in COPD, and in the preparation of this talk, I learned that horizon scanning is about early signs of something that is new, important, will have effects, and bring opportunities and threats. So I selected 3 areas that, in my opinion, will constitute major challenges in the next decade in general, and I will discuss them in relation to COPD, specifically how and why they are going to modify the trends in COPD research, They are going to impact medical care, and they are going to change the way we train students and specialists. The first of these challenges is aging. Life expectancy has increased all over the world, and the number and proportion of people older than 60 years is going to increase dramatically. But living more years doesn't mean living free of disease, and health professionals will face new patterns of disease, the most important of which is multimorbidity, already mentioned by previous speakers. It's estimated that 1/4 of the population suffers more than one chronic disease, and this proportion is increasing with age. The problem is that current medical practice, as mentioned before, under-recognizes, under-diagnoses, and under-treats multimorbidity at the same time that some multimorbid patients, including some with COPD, suffer the consequences of overtreatment due to the lack of consideration of drugs interaction. And here in the bottom right, you may identify pneumotox, which probably you are users of. So now we have a poll. How do you think the aging of the population is going to affect COPD? And you can vote. In no way, because COPD is produced by smoking. We will observe an increase in COPD prevalence. COPD patients will suffer more comorbidities, or 2 and 3 are correct. And you have some seconds to vote. I hope it's working. Okay, I can now I can see the result. Most of you, almost all of you, voted for the 4th. So can we go to the? No, I'm moving. So yeah, actually, this is the best guess. Probably, even if we could decrease COPD incidence, it would increase in prevalence because of the aging of the population. And we expect, because of this aging, patients with COPD to have more comorbidities. So it is not new. It is well known that patients with COPD, as seen in the left, suffer more concomitant chronic diseases than patients with other chronic conditions, and that this coexistence is not due to chance and not explained only by the sharing of risk factors. It has been also reported, and the first speaker mentioned this, that a subtype of COPD exists, which is characterized by systemic problems, inflammation, cardiovascular problems, and obesity. So a kind of COPD with many comorbidities. Moreover, it has been also shown that these comorbidities coexisting with COPD may start early in life, as subjects with low levels of FEV1 at peak lung function have more and earlier comorbidities than those people with higher peak lung function levels. However, in my opinion, to face the current challenge, we need to change from a paradigm from a patient with COPD and comorbidities to a person with multimorbidities as the concept. Focusing on multimorbidities instead of the coexistence of single conditions has allowed identification of biological pathways that are relevant to understand the etiology and the mechanisms for some diseases. And this is shown in the left, for instance, for the allergic multimorbidity pattern. This is the coexistence of asthma, rhinitis, and eczema. But this has not been so much the focus on COPD. Also, a different approach, and this has been very common in cancer, has been focusing on inverse comorbidity. So this is the lower than expected probability of one disease among subjects with an index disease. This has also allowed identifying causes of individual diseases. So I think that this is certainly an area where more research is needed in COPD. But for the future, it's not only research. Also, health professionals and health services will need to adapt to these changes in patterns, not only to be more effective, but to be more efficient. The changes need to be towards more integrated care, more patient-centered strategies, and also the training in multimorbidity, training in frailty, and more broadly speaking, tackling ageism and other forms of abuse. The second challenge is climate change. So climate change is the single biggest health threat facing humanity. It will affect our demographic structure, socioeconomy, and politics. It will change the distribution and patterns of risk factors, causes of disease, and it will eventually impact all areas of human health. So in your opinion, how is climate change going to affect COPD? It will not affect it because COPD patients already have a disease. We don't know, but it's likely to increase the frequency of exacerbations. We don't know, but global warming is likely to reduce the frequency of exacerbations, as exacerbations come in cold weather. You have some seconds to vote. And okay, most of you voted for the second option. Yes, that would be my bet as well, but we really don't know. There are some indications, some clear indications that climate change may affect negatively COPD and specifically the risk of exacerbations. The figure in the left shows the percent of COPD admissions attributable to high temperatures in England in the last decade. We are only starting now to calculate, to compute how big is this problem for COPD, and we need to continue doing so. The figure in the right shows the relation between air pollution and first COPD admission as surrogate for COPD incidence for several pollutants. And in all cases, the more pollution, the more COPD incidence, and importantly, this association is seen at relatively low levels of air pollution below WHO guidelines. So it's difficult to predict if global warming will, for instance, increase ozone levels, and this will have an important impact in COPD exacerbations. As for other factors related to climate change, we still don't know, but it's likely that higher temperatures, air pollution, and extreme weather events like storms or heat waves will change the amount and content of pollens, and this will certainly have an impact in exacerbations in patients with an allergen component. And we also don't know, but it's likely that the advent of new infectious agents combined with the loss in biodiversity and the severe deforestation will have an effect on the amount and type of infections, and therefore, again, COPD exacerbations. It's also worth to mention that COPD itself can actually worsen climate change situation. It has been estimated that more than 4% of carbon footprint is due to healthcare activities, and most of it to hospitals and long-term care, where COPD is included. At the same time, some inhalers widely used in asthma and COPD produce greenhouse gases, which makes it difficult to balance between individual patients' needs and collective environmental needs. And this is a problem that most of you are probably struggling with. So in the coming years, we will need to investigate more on the effects, the mechanisms, and interventions to mitigate the impact of climate change on COPD. And at the same time, as health professionals, we need to prepare ourselves to communicate and advocate for climate change mitigation, including action with patients. And I'm showing you, if you have curiosity, a leaflet prepared by European Lung Foundation on how patients can be informed and take action in this area. Finally, patient's voice. It is not a novelty that the traditional paternalistic relation between physician and patient, in combination with an excessive role of technology during medical visits, can put at risk the success of health professional actions. But nowadays, this is in contrast with increasing interest in patient involvement in healthcare, on taking decisions about their own health, and also their interest in being involved in research. So the question is, how often do you ask open questions to your COPD patients or include patient's voice in your COPD research? And I think you have voted. Okay, most of the responses are, well, the responses are divided often and rarely. Okay, I think this is not something that we are used to do usually, at least in research where I am most involved. But this is in contrast with current trends. So nowadays, patients claim to be part about their decisions, about the decisions involving their health, both at the individual and at the collective level. But there have not been attempts to measure this in research. Table in the left shows a paper from 2014 about the net effect of roflumilast in COPD after subtracting the harms due to side effects, insomnia, diarrhea, depression. In most cases, and under different scenarios of how much patients would accept the side effect, the net benefit was zero, with the exception of patients at high risk of severe exacerbations. So one would think that this, considering benefit minus harm, should be a standard approach to evaluate effectiveness. But actually, numbers in the right show that in comparison with more than 900 papers about the benefits of drug treatment in COPD in PubMed, when we add the term harm, only 4 papers remain. So there is a lot of work to do in research to quantify the patient's interest. This figure shows what can be done with actively involving COPD patients in research. It shows a conceptual framework of what is working from the patient perspective and was built from a systematic review of evidence coming from qualitative research with people with diverse chronic conditions, including COPD. Walking is reported as a physical, social, and mental experience, which is framed by the context and activities. These experiences link the individual walking activities to their sense of self through behavioral and attitudinal adaptations, and in turn, these adaptations affect future experiences and the participation in activities. The building of this kind of frameworks is obviously important for research, but it's also important to guide health professionals involved in the care of these patients. And this can help, for instance, when the previous speaker was talking about personalizing the physical activity recommendation interventions. And not only research. Nowadays, the regulatory agencies like European Medicines Agency, the Food and Drug Administration, require that patients' experience and preferences are clearly reported when approval is sought for all kinds of medical interventions. And also, as mentioned above, patients and carers, also COPD patients, are very often well-organized, and patients' organizations have become real professionals of advocacy, so they shouldn't be ignored at any level of healthcare. In summary, the future is unknown, but I hope I have convinced you that multimorbidity, climate change, and patients' will to be heard will have an impact in the clinical manifestations, research, health services organization, and medical treatment around COPD in the coming years. And I hope that you are now motivated to learn more about each of these topics. Thank you.
Judith, thank you so much for a fantastic presentation. You know, it's funny because Nicola and I were joking at the previous presentation that Thierry had about the patient, his hypothetical patient who had a grandchild that they looked after on Wednesday. And you know, on the patient voice, you know, the clinician side was saying, well, there's a vector for infection. And on the patient side, it's probably the most important activity of the week and the hook for getting them involved in activity. So that's a fantastic presentation and a great link for all of our talks. So thank you for that. I've now the great pleasure of asking each of the chairs of the various respective societies who are participating to bring on their questions. Bernardino, what questions have you got?
Okay, so thank you, Richard. I would like to ask Professor Halpin one question about treatment of COPD. Your talk is very excellent. It's been exciting to summarize all the goal recommendations in 20 minutes. So I really must say that your talk was just fantastic. I have to say or ask you about one thing about behavior. Is that one of the most important things on behavior in COPD is probably the adherence of treatment, of inhaled treatment. As many other chronic conditions, adherence in COPD is low or tends to be low after 1 or 2 years. the patient start a treatment. So which are, in your opinion, which are the key factors for improving adherence to inhaled therapies in COPD? Is just only to put all the inhalers in one? Is a matter of the dosage regimens, or there are factors that we cannot modify within a single patient?
So I think that's a real challenge. I think there are some things that are in our control, and there are other things that are not in our control. So as you mentioned, I think if we're talking about inhaled therapies, then actually making sure that the patient is comfortable using the device is important. If they find it difficult, then that will have an impact on adherence. If they have to use multiple devices and multiple times in a day, that will influence adherence as well. So trying to keep it simple and keep it to a device that the patient is able to use, I think will help with adherence. Alongside that, I think is education. So trying to help patients understand why they're on a treatment. So, Judith just talked about the patient voice. If what matters to a patient is being able to look after their grandchild or being able to walk upstairs, and we can help explain to them, by taking this medication regularly, this will keep you healthy and will enable you to do the things you want to do, I think that improves adherence as well. But adherence is a real challenge across the whole spectrum of medicine. And it always struck me as really quite astonishing that, for example, women after treatment for breast cancer, their adherence to hormone therapy or to other treatments was only about 50%, so as good or bad as we see in our inhaled therapy. So on the whole, people don't like taking medication, and we need to remind them of the importance of that and make it as simple as possible, and look out for side effects and try and understand why it is that they may not be taking something. In some cases, it can be because they think, if I take it all now, I'll have nothing in reserve. In other cases, they think, I'm getting a side effect, so if I don't take it, I'll feel better. So it's that understanding as well.
Thanks, David and Bernardino. That's a great question and a topic quite close to my heart, I have to say. So very well answered, David. I completely endorse it. And I've been studying personally adherence in patients, and we've studied well over 1,000 where we've had the opportunity to ask them the cause of their non-adherence, and we have at least 1,000 reasons why people don't take their treatment. And sometimes simply measuring it and then finding out what's driving it is a good and simple and pragmatic way to do it. So thanks, Bernardino. Cindy, what question have you got for the panelists? I'm sure you've enjoyed the talk, so you've probably loads of questions.
I have a question to Rosa, but also to Professor Halpin. I can start with Professor Halpin. My question was, when should we check the eosinophil blood count in COPD patients? Should we do this now in every patient, or should we reserve it just for patients with frequent exacerbations? What do you recommend?
Sure, well, it's a really good question. So in the UK, almost all patients with COPD will have had a full blood count for one reason or another. So we have a record of their eosinophils in the record without needing to check it prospectively. I think if that doesn't exist, it's worth checking it at the point at which you're considering prescribing an inhaled steroid. And that would be, as you say, perhaps in patients at risk of exacerbations. The key points are that it shouldn't be done when somebody's on oral steroids, because that will obviously suppress the count. And we should, this is a global educational meeting. We should be aware that there are other causes of high blood eosinophils, parasites, things like that we need to make sure are not driving the count. But if you have a historical count within the last year or two, with somebody not on steroids, no other cause, you can use that. If you don't have it, then you can do one when you're considering an inhaled steroid prescription.
Okay, thank you. Perfect. And I have also a question to Rosa. I was very interested to hear about young COPD, and I was wondering if, besides smoking cessation, are there any specific treatments in young COPD or pre-COPD? And I was specifically thinking about inhaled corticosteroids. Do you think that they may slow down FEV1 decline in this particular population? And are you aware of any therapeutic trials already ongoing?
So thank you for your question. I think that's very interesting. I would say that the evidence saying that if a person has young COPD would benefit of the decline on FEV1, it's still, we don't have that evidence yet. So for these people that have young COPD, but it's from the, not from a general population, just from the clinical setting, I would suggest that it should be treated as if they were of all COPD, because all these phenotypes of young COPD, we don't know them yet. So that would be benefit. I would recommend that you use the same guidelines, no? So the exacerbations and all that, what you already know from all. But because I think in the future, we will know more about which are the specific phenotypes of young COPD that we will benefit from specific interventions, but we are not yet there yet.
Okay. Thank you very much.
Thanks. Flora, what questions have you got for the speakers?
First of all, I wish to congratulate the speakers because they focus on a very important aspect with young COPD patients, and it was a link between all the presentation. My question is, first of all, for Thierry, and I have also another additional question for Judith. For Thierry, because I saw we have this sample of patients doing physical activity, exercise training, and rehabilitation. But we have a certain category of patients who are smokers, despite our advices, and they make physical activity. How we can choose the moment, the right moment, what are the criteria to change from this physical activity to rehabilitation? And if we are starting rehabilitation, how long it must be? Can we speak about chronic rehabilitation?
Thank you. I think that's an excellent question, and it's one that I think is relevant for many clinicians. The reason to give an exercise training program as a component of a rehabilitation program is when the physical fitness of patients is impaired. And so that is something that you can find out if you do an exercise test, for example. It can be as simple as doing a 6-minute walking test, or if you would measure muscle function in patients and you find that there is muscle weakness in patients. And this is actually the case in many patients with chronic obstructive pulmonary disease. So I would say if a patient shows that there is a reduction in his functional exercise capacity, or if the patient has significant complaints of reductions in exercise tolerance, then that patient is up for an exercise training program as part of a pulmonary rehabilitation program. As long as that is not the case, the recommendation should be to encourage patients to engage in as much physical activity as possible. And that's actually a recommendation that holds true for the whole population, also for you and me and the whole audience. It's important that we engage in roughly 30 minutes of physical activity at moderate intensities, which means that it makes you a little bit out of breath. And that's what moderate intensity means. So I would say verify regularly how patients are feeling when they are engaging in exercise. And if you notice, if you have the sense that there is a reduction in exercise capacity, exercise tolerance, do a formal test of functional exercise capacity. Can be done by your physiotherapist or a nurse in your hospital. Do a 6-minute walking test. And if that 6-minute walking test then becomes abnormal, the patient would benefit from an exercise training program. In terms of your question related to smokers, I think that is an important question also, because in many countries, smokers cannot get rehabilitation. They first have to quit smoking. I would disagree with that. I think exercise training and rehabilitation is a treatment that we offer patients. And if you have a smoker that steps into a rehabilitation program, that is actually a good moment to also quit smoking. So I would definitely make sure that also people who smoke can be enrolled in a rehabilitation program and then hope that they quit smoking along the way.
Thank you. And for Judith, I saw it was very important to face this modern life for COPD patients. But we have another additional problem in this moment. It is an offer from tobacco industry, e-cigarette and heat-not-burning tobacco. What is the impact? What we have to do? Because this is additional to the climate changes. Thank you.
Yes, that's a very interesting point. There are many challenges facing, so I just selected 3 of them. How is e-cigarette use going to impact COPD? We don't know, because we still haven't had enough latency time, let's say, since the epidemics of using e-cigarette started. So we don't know if this is going to increase the risk of COPD. Probably it will. So that's maybe we will need to adapt COPD guidelines and include as a risk factor e-cigarettes. So that's certainly an important point. I think that for health professionals, the attitude should be discourage the use of these e-cigarettes, and that's it. And for respiratory, but for also all types of health issues.
Thanks. Nicoletta, what questions have you got for the panel?
I have a question for Professor Garcia. I heard with great interest the patient's voice impact. So in choosing the treatment in patients with COPD, and I find it quite crucial to take into account the everyday experiences of our patients, because dyspnea is not the same for all patients and patients' lives. So is there a strategy, a policy that you could propose in order to raise awareness among healthcare providers and pulmonologists specifically, so as to engage more in taking into account the patient's voice when deciding and when, let's say, planning the treatment choice for the individual COPD patient?
That's a very interesting point. I'm not aware if there is a general policy or guidelines on this, but I think there are many, many ongoing activities in this line. And ELF, the European Lung Foundation, is doing many activities to promote the patient's voice in research in clinical care. So maybe including a section on how patients should be involved in treatment in the clinical guidelines for each of the diseases, that could be a first starting point. I don't know if all diseases already include that, but that's something, that's work to do, clearly important. Thank you.
Thank you.
Okay, that's great. We have plenty of questions from the online audience, so that's also something great. Thanks a lot to all of you who are heavily participating all over the world. That's great. Well, we will not be able to address all the questions, definitely. So sorry, I apologize for that. I'm going to go through each of the speakers, one question each, and then go back to the first one if we have time, and then follow on like this. So, first question will be to Rosa. Maybe it's a simple question. In terms, if you compare young and old COPD, is there a difference in the amount of emphysema in these patients? You could imagine that in the younger you have less emphysema, except if they have, a tendency to have emphysema more quickly. So, do we have some insights from the studies, or is it something still unknown?
So, there have been studies, I think some work is still not published, but they have been comparing characteristics of young versus old COPD. Young COPD, surprisingly, I would say they have more emphysema and of a different type. And the tobacco smoking is different, of course, because they are younger. But we don't know if that population is more at risk of more mortality. So I think we will see more studies, and taking into account if the amount of emphysema will decline and if these people really reaches the 65 or is the population that dies earlier. So that's what I can reply for now, but I think it's a very interesting and important field of research.
Okay, thank you, Rosa. Now, question to David now. There are some questions around why GOLD doesn't use the LLN or the lower limit of normal or Z-score for FEV1 and FVC ratio. We know these are ongoing areas of debate. And there is another, so maybe we won't have time to discuss all that. It can take, well, not years, but many hours. But another question I find interesting on this topic is, do we need new tools to diagnose airflow limitation or airways obstruction, whatever you choose? For example, forced oscillometry, or is FEV1 and FVC, whatever you choose between the LLN or fixed ratio, is it the right tool, or do we need something else?
Sure. So, I mean, we've talked about this a lot over the years. First of all, to try and clarify GOLD's position, low limit of normal has some advantages, but it's not the gold standard. And if you look at survival, fixed ratio is as good as lower limit of normal. There are no good predictive equations for post-bronchodilator lower limit of normal. So that's one of the practical limitations. I've always been a pragmatist. I think it's important to get clinicians doing spirometry, and we've spent 20 or 30 years in the UK working really hard to get primary care to do spirometry. If you make it too complicated, they'll just give up. So I think lower limit of normal is a scientific debate rather than a practical debate. Whether other measures rather than FEV1 would be helpful, I think is also relevant when we come to think about the pre-COPD, because it may well be that these people have quite significant small airways disease, and we're calling it pre, but actually it is early COPD. It's showing definite physiological abnormality. Again, I think it's a pragmatic thing. If the tools required to identify these changes are quite sophisticated, only available in laboratories, they may be relevant for some patients, but not as a population level. And one of our big challenges is all the millions of patients with COPD who've not been diagnosed at all. And I think the alternative approach is newer technologies. I was reading a paper in a electronic engineering journal the other day about an app now that will pick up with something like an 80% positive predictive value airflow obstruction based on you talking into your smartphone. And what we need is simpler methods of screening for airflow obstruction that then may need to be confirmed with more sophisticated tools. So that would be the direction I'd go in, rather than more sophisticated physiological measurements.
Okay, thanks for that. I think it clarifies a rather complex issue and make it, you need to be straightforward in a way. So thank you, David. Question for Thierry. Actually, I will group two questions because they may have a link. One is, how should we use digital platforms, mHealth, eHealth, whatever you choose as a term to name that? And the second part of the question, which I think has a link, is, should we prefer group or individual rehab? And well, digital, it might be difficult to, well, it can be individual and group, but it's more challenging. So first, the digital and then group, or the other way around, as you wish.
Yeah, excellent. And I think that is a modern question, because telerehabilitation is something that is finding its way. And during the COVID pandemic, we've learned a lot about telerehabilitation and how it could integrate. I think I wasn't a big fan, but what we learned during the COVID pandemic is that it's definitely possible. And in fact, the studies that have compared telerehabilitation to conventional rehabilitation typically show equivalent results, and perhaps even more long-term results after telerehabilitation. So I don't think we should necessarily be against it. What I would say is that if you use the ATS workshop report, where it is specifically said, okay, these are the components of a rehabilitation program, and you manage to integrate those components into a telerehabilitation platform so that you can make sure that patients have an appropriate dose of exercise, are also guided towards more physical activity, that there is counseling for patients that feel anxious or depressed, and perhaps an intervention also by a nutritional expert that is available, this is definitely a good avenue to pursue. About the group or individual sessions, I think the group sessions are definitely what our patients prefer. Once they are involved in a group of patients, they become sort of a friends group. And you could link that with tele-rehabilitation. And I think one of the nice things that we've learned, again, with the pandemic, is that through simple platforms like Zoom or Teams, you could set up a tele-rehab with different patients that could also have interactions with each other. And it's learning from each other. And it alludes a little bit to what Judith was talking about. Use the patient and the strength of patients to learn also from each other. That helps, and that makes that group dynamic, that makes rehabilitation in group even better than rehabilitation alone. I'm not sure I know a study that looked at the effect of individual versus group rehabilitation to show benefits of one or the other, but my practice is rather that a group rehabilitation creates a dynamic that is hard to obtain from an individual session. In addition, of course, the human resource cost is a bit less. If you need one physiotherapist for one patient, it's of course much more costly than when you have one physiotherapist for a group of a couple of patients.
Okay, yeah, great, very insightful. Thank you for this answer. So, as promised, I will now move to Judith. And my question will be, I'll take this one, on cannabis. We touched on vaping, e-cigarettes, but regarding cannabis or any other, inhaled drug use, what are the trends in a way? What's the impact? There are some people who don't smoke tobacco but only cannabis. What's the effect? What's the effect if you mix them? Do we have enough studies to answer these questions? So what would you say?
Honestly, I don't know about the answer. So probably cannabis is going to affect, I think some of the health effects in other organs like the brain are worse and maybe do not allow developing COPD because people will die sooner. So, but it should be related probably to an increased risk of COPD. Whether this is a challenge for the next decade, if the use is been changing, I'm not sure about that. I don't think there are clear patterns. There is a clear increase in the population of the use of these drugs now. What I think is that at the population level, the initiation age has started in relation to tobacco and probably other drugs. And whether this may mean that we will see young or earlier COPD, this is not known. We need still the time to come. But
okay.
that would be my guess.
Yeah, okay, but that's very important because what I understand from what you're saying is that we definitely need more research. So it means that we need to engage also researchers to go in that direction and gather more data on this. Another question to you, Judith, which I hope it is not as tricky as the previous one, and I hope you will have more data that you can use. But it's a practical one. We are facing more and more climate events such as heat waves. With heat waves, we have more pollution, etc. What would be? Do we have enough data to give advice to the patient, and which advice, for example, should we give them when there is a heat wave? What should they do?
Yeah.
Should they stay, at home and wait until it ends? Should they still move? Should they put the air conditioning on, which is bad for the climate, but better for their health?
So clearly, we need more research in that. So there are going to be effects on COPD patients in the prognosis of the disease as they have, as the effects are for the general population. What we don't know is whether COPD patients will be more vulnerable than other people, or let's say other elderly people, to these extreme events. So we don't know that, and we need research on that. obviously, if we don't know that, we still don't have information on the potential interventions to mitigate the effects, and we need to research on that. In absence of this knowledge, we would need to use the traditional recommendations. So patients need still to be physically active, because it's worse to be physically inactive than to be exposed to air pollution or heat, let's say. They should be encouraged to do their physical activity practice in the time when the weather is better, in the time and the place where the air pollution is lower. Use masks if these are possible. Check the forecast. Keep well hydrated. So the normal recommendations that you would do to an elderly person, they should work for COPD patients.
Okay, yeah, thanks a lot, because you say normal advice, but I think it's important to remind people what these normal advice are, because probably we tend to forget a bit about these, and patients ask. So thanks very much for this. I'm going to go back to Rosa, and I have a question. I don't know if there is an answer. Given all the work you showed on the biomarkers in the various stages in terms of age, etc., of COPD, do you think there might be some room for biologics targeting TSLP or other alarmins? There are some studies ongoing with the anti-T2 for those patients with some eosinophil phenotype. But for TSLP, do you think this could be a target in COPD?
I think that in those patients that fulfill the mechanism of TSLP requirement, yes, no. So if you have someone that has some characteristics similar to what is used in asthma, no, so then yes, it would not be an overlap. But we know that not some patients have reversibility, some patients may have eosinophilia, some patients may have also concomitant asthma. So I don't think yes. I think yes, but the studies should be conducted. I think we have to move towards recognizing to which patients need an anti-IL-4 or an anti-TSLP or the TSLP can be used, or even something like targeting the neutrophils. So I think there is room, but we are moving towards identifying to which patient this should be used, and it's not to everyone.
Okay, yeah. Okay, let's move to David. Very practical question. You insisted a lot, and certainly right, to insist on that, on the comorbidities, on the multimorbid condition, and on the need to assess a bit systematically the patient for this. From a very practical perspective, how do you do that? And maybe focusing on anxiety and depression, do you have a questionnaire that you use, or do you have questions that you systematically ask the patient? How do you do that?
Sure. So, I mean, there are questionnaires. There's the HAD scale, which is used in research, but is not really terribly useful for routine clinical practice. There are a number of others. One of them was developed for identifying postnatal depression and is a series of simple questions that you can use. I tend to just talk to patients. So I discussed this with primary care colleagues some time ago, and they said in their experience, identifying anxiety and depression, the best way is to ask patients, say, do you get a bit down sometimes? How does that affect you? Do you get a bit worried? Do you get anxious when you get breathless? And patients then begin to talk about it. So I think you can identify it clinically, but if you want to use questionnaires, there are a number designed for clinical practice as opposed to research practice.
Okay, yeah, that's clear. Thierry, well, I have a question that might be strange, but actually thinking about it, I find it interesting. Is there an effect, you're going to be surprised, is there an effect of rehab on blood eosinophil count? And I think the idea behind that is that we know that physical exercise, physical activity is anti-inflammatory, whatever it means in that context. Are you aware of any study? I can't think of any, but are you aware of any study measuring eosinophils after and comparing to before rehab? Maybe the answer is no, and it will be quick.
Yeah, so the answer can be a quick no. I'm not aware of any studies. What we do know is that rehabilitation has an impact on exacerbation rates and the risk of being readmitted to hospital after an exacerbation. But there might be work, but not that I can sort of bring to the stage right now.
Okay, but it's interesting. It's something we need to check. So I will have another question for you, which is, which one I'm going to, you showed us a graph with the effect of bronchodilators, the effect of rehab, the effect of both, which was bigger than each of the others separately. Is it an additive effect? Is there some synergy? Do you think bronchodilators facilitate or increase the effect of rehab, or it's just the addition of the two of them?
No, well, theoretically it should be synergistic, because if you give a patient a bronchodilator, that patient can actually train harder and will have more effect of the exercise training program. So because there is a dose response in terms of how much you gain from exercise and the dose of exercise that you got. So these effects are synergistic rather than just cumulative. And there's one nice study, I think, that looked at it also by the group of Richard Casabury, and they nicely showed that if you give a patient a bronchodilator and then you give a patient an exercise training program, that if you look at the effect of each of those, that the effect of the combination is actually bigger than the effect of each of the interventions separately. So it really goes hand in hand, and it makes sense because with exercise training, you're focusing on the muscle and on the cardiovascular system. With a bronchodilator, you're actually improving lung function. So it's not too weird that if you combine both, that you get a better and synergistic effect.
Okay, that's very clear. And so I think the last question will be for Judith. You touched on the patient voice, and definitely that's something very, very important. What about the relatives, the family, the friends, all the patients who are moving, all the people, who are moving around the patient? How should we deal with them? How should we listen to them?
Yeah, I think they fall under the same basket as the patients. So the point here is that there is this general trend towards patients and carers asking to be more involved in the decisions about their treatment and in the research about their disease. And this is not going to stop. So that's it. And we need to be prepared for that. Those working in research, those working in the clinical setting, this is going to increase, and we need to hear to them.
Okay, that's very clear. So, well, now I think it's time to thank you all. Thank both, well, my co-chair, of course, and the national chairs that we had with us. And of course, also thank our speakers. These were really wonderful talks. We learned a lot of new information, a lot of very practical information. So I think we have a lot to bring back home, which is great. Now, we also need to thank the audience for attending first, and then for participating. And again, sorry for not being able to ask all the questions we received, way too much, which is great. So now we have a 1 hour break, and we need to reconvene for all those who will be able to do so in 1 hour from now, which would be 2:30, 14:30 CET, and we'll have a nice lunch or whatever you're going to do during this hour. And we will have asthma and ventilation in the afternoon.
Thanks everybody.
Bye.
Thank you. Bye.
Thank you.